Welcome everybody to today's Penn AI Tech webinar. Penn AI Tech is the Penn Artificial Intelligence and Technology Collaboratory for Healthy Aging, an initiative here at the University of Pennsylvania funded by the National Institute on Aging. Today, we're very happy to have with us as our speaker for today's webinar, Dr. Julia Adler-Milstein, who's a professor of medicine and chief of the Division of Clinical Informatics and Digital Transformation at the University of California, San Francisco. She conducts empirical research that guides the U.S. healthcare system towards effective health information technology adoption and use. Her specific expertise is in policy and organizational strategies related to the use of IT in healthcare industry and healthcare delivery, and her research assesses the progress of health IT adoption, the impact of such adoption on healthcare cost and quality, and the relationship between market, organizational, and team structure and health IT use. This work includes studying the adoption and use of telemedicine, and over the past 5 years, Dr. Adler-Milstein's work has shifted to focus on the use of health IT to support care of older adults and in particular people with dementia. I want to remind our attendees that you can post any questions you have using the Q&A feature on your Zoom. And at the end of Dr. Adler-Milstein's talk, we'll get a chance to answer questions and have a discussion. So with that, thank you again, and I'll turn it over to you, Julia.
Great. Well, thank you so much for that lovely introduction. And I'm really thrilled to be presenting in this seminar series. I feel like over the past 6 months or so, there's been so much discussion about how AI and emerging technologies are going to impact how we care for older adults. And so this is a really important venue to be having those discussions. So I am excited to be able to share results from an ongoing study that we have been working on at UCSF with colleagues at Kaiser Permanente, Northern California. That is, let me just get into the right slide mode. That is focused on understanding how the large-scale expansion of telemedicine that happened, as we know, quite rapidly during the pandemic, has impacted primary care receipt for people with dementia. And we're drawing on evidence from both UCSF Health, which is an academic medical center, and Kaiser Permanente, Northern California, which is a very large community-based health delivery system. So the motivation for this work, as I said, was the recognition that, telemedicine, I'd say without, a lot of time for thoughtful planning, expanded to become integrated into primary care. And this is, important to think about in general. And there's been a lot of research to assess the expansion of telemedicine as this integrated modality of care, rather than as sort of a wraparound service to traditional face-to-face care, and to think about how it may impact specific populations that have unique care needs. And so for those with dementia, as well as their caregivers, primary care is a really critical venue to receive high-quality care. And because many of the assessments that go into both diagnosing and caring for people with dementia may be impacted by not having face-to-face access, it's particularly important to understand then how this expansion of telemedicine impacted that population. So as I said, we were very curious to be able to study this, ideally at a level of scale where we could draw some generalizable conclusions. And I think we're fortunate to be able to partner with Kaiser because they've actually been a leader in telemedicine even preceding the pandemic. And so it allowed us to compare one health system, our health system, UCSF Health, that did almost no telemedicine until the pandemic and then rapidly expanded, as compared to a health system that had been working with telemedicine for quite a long time and still expanded it during the pandemic, but with a lot more experience. So we take these two health systems and then focus our study on the implications of the COVID-induced expansion of telemedicine across different dimensions of care for this population. And we're interested in things such as equity of use, timeliness of care, and subsequent near-term utilization as potentially a sign that telemedicine was not being used in a safe and effective way. If, for example, we saw after a telemedicine visit higher levels of people with dementia needing to use the ED or being hospitalized. So our hope is that by studying retrospectively what happened after telemedicine was expanded coming out of the pandemic for this population in the primary care setting, that we can develop some specific strategies that will help tailor telemedicine use in the primary care setting to better meet the needs of this population. And so I'll tell you at the end about the next steps that we have planned that will move from a sort of retrospective analysis of electronic health record data to surveys of primary care clinicians based on a literature review, where we'll try to generate an understanding of what is working well and what could be done better to tailor telemedicine to this population. So the specific research questions that I'm going to address today, where we're sort of midway through this study, is that we started with just understanding the composition of modalities of care that are utilized and how that changed pre to post pandemic. Again, this is specifically for people with diagnosed dementia who are receiving primary care. And then we do a deeper sort of drill down into that to understand the socio-demographic characteristics that are associated with use of telemedicine versus in-person care, focused on the post-pandemic period, because that's obviously our representative of our new normal, and to try to understand if there are differences for phone-based telemedicine versus video-based telemedicine. And then we move on to the timeliness question. So does encounter modality impact the timeliness of care? In particular, our hypothesis is that telemedicine might help people with dementia get more timely access to primary care. And then this question of sort of unintended consequences is, does the encounter modality influence whether there's near-term subsequent utilization, such as ED visits, hospitalizations, or follow-up in-person primary care visits? So I will give you this set of results today, and then, as I said, turn at the end to what's coming next for this study, and would really welcome ideas and thoughts from your own contexts and experiences about where we may need to better understand how to tailor telemedicine to support the needs of people with dementia in the primary care setting. Okay, so the first thing we had to do was to figure out how to identify all people with dementia that were receiving primary care at these two health systems. And so we used as our definition that they needed to have at least one evaluation and management visit in a primary care setting by any modality, whether that was in-person, phone, or video. And so anyone who met those criteria, we looked at that for two different periods, our pre-COVID period, and then we had a sort of COVID washout period. And then the post-COVID period starts in March 2021 through February 2022. So you can see sort of date-aligned periods in the pre and post-pandemic. We spent a lot of time figuring out how to define dementia in ways that were consistently captured in the electronic health record of both institutions. And so we ended up using a set of ICD-10 codes recommended by a consortium for detecting cognitive impairment, and actually expanded them a bit based on some expert panel input. Defining E&M visits may sound straightforward because it's obviously defined in part by CPT code, but we did have to think about sort of who was delivering those visits. And so we limited them to those that were delivered by a physician, NP, or PA. So that led to our cohorts, and then we had to then define the encounters in primary care for those individuals. And it turns out that it's not so straightforward to figure out whether an encounter is a phone, a video, or an in-person encounter. And so we basically had to sort of piece together Epic's visit type name field. And basically, if it included the word phone, we assigned it to a phone-based. If it included video, we assigned it to video, and then everything else we assumed was in person because there wasn't a specific label for in-person encounters. And then for each encounter, we captured to support the timeliness and subsequent utilization analyses. So timeliness is basically the number of days from when the visit was scheduled to when the visit occurred. So if you called on, a Monday and you got seen on a Friday, right, that would be the, 5 days from when it was scheduled to when the visit completed. And then the subsequent utilization, we looked at that in the 14 days after that index visit. And again, we captured whether there was an ED visit, whether there was a hospitalization, or whether there was a follow-up primary care visit. Obviously, some limitations to those because they had to occur at the home institution. For Kaiser, that's a pretty safe assumption because they're a closed system. But for UCSF, there is the possibility that we miss some visits if they went to an ED that wasn't part of our system. So to answer our research questions, again, the first one was just very simple, which was to descriptively characterize like how the composition of care across phone and telemedicine changed in the pre versus post-pandemic period. But then we went on to use multinomial logistic regressions that basically assess changes in modality use pre to post pandemic and look at those in terms of different types of patient characteristics. And I'll tell you about those in a minute. And we looked at those both at the patient level, like did the patient shift their composition of encounter modalities, as well as at the encounter level. So did the mix of different encounter types across the whole population change? Then for timeliness of care, we limited those analyses to encounters that were sort of in the 0 to 30-day scheduling to visit window. Because what we didn't want is someone who a year out schedules their annual wellness visit for the next year, right? Because there we're not thinking about telemedicine as being such a crucial factor in timeliness of care. These are really sort of more emergent needs where you really would need to see someone on a shorter time scale. So we limited that analysis to that subsample. And then again, used linear regression to compare timeliness across modalities so that we can see if you had a telemedicine visit, was there a shorter scheduling to visit time than if you had a face-to-face visit. And then that adjusts for covariates like age and comorbidities and time since dementia diagnosis. And then last but not least, the subsequent utilization. Again, this was sort of 14 days after the index visit and just the likelihood of having a hospitalization or an ED encounter or an in-person primary care visit or none of them. And again, using logistic regression models that adjusted for the same covariates, but also adjusted for the timeliness variable. Okay, happy to go into more of the details of the analytic approach, but just wanted at a high level to give you a sense of what we did. So in the first research question, I keep talking about these focal characteristics, and we actually did quite an extensive literature review to identify those, and I'll show you the hypotheses in a minute, but I just wanted to delve into those so you can see what they are and how we measured them. So for age, we grouped them into these categories that you can see here. Limited English proficiency is basically defined as 1 if the patient's primary language is anything other than English. So it's not a perfect measure of limited English proficiency. It's really more of a proxy measure. Neighborhood socioeconomic status is determined based on the patient's home zip code and uses a UCSF health atlas that we've developed that characterizes the basically the socioeconomic demographics of the neighborhood the patient lives in. Driving distance from clinic is miles between the patient's home zip code and the clinic's zip code. And then this was one I have to say that was actually not in our initial analysis, and our reviewers asked us to add it, and it's a complicated one, it turns out. What they wanted to know was, does presence of a caregiver matter in terms of the modalities? And I think it's actually a very reasonable question and very important in this population. But there are 2 challenges with it. I think one is that like the vast majority of people with dementia do have caregiving needs, and particularly when they're trying to access care. And so we sort of assumed that like everyone would have some caregiver help. And then there's the question of if they did, was it documented? And there's not a standardized field for whether a caregiver supported the encounter. And especially for telemedicine, it might not even be visible to the care provider whether there was a caregiver that was there doing the work in the background to help that individual, connect to the visit. But because the reviewers asked us to, we did our best to capture it. And we basically had to look at the encounter note, and it was coded as a 1, like that there was presence of a caregiver if the note included some term indicating that there was a helper or a daughter or a son or a spouse. We tried to think of every word that could indicate that someone was there to help. So it's not perfect, but I hope at least like a somewhat reasonable proxy. But again, I think we were just skeptical whether that is going to be a meaningful predictor in this population, given that we think that everyone to some degree likely had a caregiver for either in-person or telemedicine based care. Okay, so this is a bit of a busy slide and we don't have to go through all of our hypotheses, but we did actually start with a literature review to develop our hypotheses for whether each of these demographic characteristics would be associated with greater use of telemedicine versus in-person, as well as if there was any literature saying phone versus video use among those with telemedicine. With a telemedicine encounter. So I'll actually come back to this slide at the end and show you which hypotheses were supported or not by our results, but I just want you to see that we did develop hypotheses before we did our first set of analyses. Okay, so a bit of a number wall here, but let me walk you through. As I said, part of the reason that we picked two different sites was because we knew they had different levels of telemedicine use, but it turns out they also have different populations of individuals that they serve as well. The first thing you may notice is Kaiser is just like fundamentally, larger than UCSF. So at UCSF, we're talking about hundreds of people with dementia who are receiving primary care. At Kaiser, right, they're almost at 20,000. So they just had a significantly larger sample than we did, again, because they're just such a large delivery system. But then we also saw some differences in demographics. So for example, UCSF had a higher proportion of patients with limited English proficiency. Again, that somewhat reflects the geographic areas that we draw from compared to Kaiser. Kaiser, interestingly, though, had more patients from lower socioeconomic status neighborhoods, and they do draw from more rural areas, which oftentimes are actually considered lower socioeconomic status. Kaiser patients had longer driving distance to the clinic compared to UCSF patients, again, somewhat reflecting the fact that we're more urban-based and they're more suburban and rural. And we had a higher percentage of encounters with a caregiver present. Again, is that true, or is that just differences in documentation patterns? I think I'm not convinced that this actually reflects reality in terms of caregiver presence at the encounter. Okay, so that's again just the basic demographic characteristics. You can see, not much change pre to post pandemic, which we weren't expecting, but good to sort of confirm that, the populations themselves didn't look like they substantially changed over time. Okay, so let's start with the results. So again, this is just descriptive. What modalities of care are utilized to receive primary care among people with dementia, and then did that change pre to post pandemic? So as you can see, starting on the left with UCSF, like really a dramatic change pre to post pandemic. So pre-pandemic, it was effectively all face-to-face care. And post-pandemic, in the steady state, you can see now that face-to-face care is like the minority, right? So only 35% are receiving fully in-person care only. 45% are receiving a mix of telemedicine and in-person, and a full 20% is receiving only telemedicine-based primary care. So again, just a massive shift that we see there. And even at Kaiser, who, as you could see, was using telemedicine at like a moderate level before the pandemic, they even saw this really large shift. And what I think is interesting is that at both sites in the post-pandemic period, you can see about 45% of both populations have this mix of face-to-face and telemedicine. So it does suggest that this is sort of a permanent, durable combination of modalities that seem to be together able to serve the primary care needs for almost half of this population. And again, you can see they're a bit higher in terms of the telemedicine only population compared to us. Okay, so now moving on to the socio-demographic characteristics results, and these get a bit more complicated, so I'll try to walk through them clearly. So this is first just saying, what are the odds of a telemedicine versus in-person encounter? Again, looking at these different demographic characteristics. And again, just remember that Kaiser has much larger sample sizes. And so more often than not, the results are the same at the two sites in terms of the directionality of the relationships. But several of them are not statistically significant at UCSF, but they are at Kaiser. So for example, one of our first interesting results was that the oldest in this population, those who are 90 plus, more likely to use telemedicine. You can see at Kaiser, that was, an odds ratio of 1.23. And so, again, not a huge effect size, but meaningful in terms of higher levels of use compared to those in the youngest cohort of this sample. For those with limited English proficiency, you could see slightly lower odds of selecting telemedicine. Again, at Kaiser, statistically significant, at UCSF, not so. For neighborhood socioeconomic status, at Kaiser, those that came from higher socioeconomic neighborhoods were more likely to use telemedicine. And at UCSF, you can see the result was actually in the opposite direction, but again, not statistically significant. So somewhat seems like different pattern of results related to socioeconomic status. Our most consistent result that was sort of, large effect size, at least at UCSF, and significant at both sites, was driving distance from home to clinic. So those who had to drive at least 5 miles to get to their clinic were more likely to use telemedicine. And then those who had a caregiver at an encounter were less likely to use telemedicine. Again, I have a lot of skepticism about whether that's the right interpretation of that. I think it may just reflect more the likelihood that that was documented rather than the actual presence of a caregiver. But you can see at Kaiser that it was associated with lower odds of selecting telemedicine. Okay, so again, that was just looking at by these 5 demographic characteristics, use of telemedicine versus an in-person encounter. And then we went and said among the subset that had a telemedicine encounter, was there a difference for selecting video versus phone? So here at UCSF, you can see like the only thing that was really significant there was that the 75 to 79 compared to the less than 75 group was more likely to select video over phone. Again, hard to know whether that's there's a meaningful signal there, and you can see the rest of these age odd ratios are just a little bit all over the place. So I don't think we're seeing strong results with respect to age and whether there's a preference for phone versus video or use of phone versus video. Again, limited English proficiency is not significant at either site, but somewhat lower odds of selecting video over phone. And then we get into some more consistent results, at least for Kaiser. So neighborhood socioeconomic status, higher socioeconomic status neighborhoods, more likely to use video. And those who were had a farther driving distance for home, somewhat more likely to use video over phone. And then again, presence of caregiver, higher likelihood of using video over phone. So again, not like a super consistent set of results here, but some things that that could suggest ability or preference to use one modality over the other. Okay, so this is, again, a bit of a busy slide, and we don't need to go through all of these, but the odds ratios just give you a sense of sort of what's higher versus lower, but it doesn't give you an actual sense of like the magnitude of the difference between the different demographic groups. So for example, if we take the distance from appointment, right, which is the 4th results down here, you can see those who had to drive 5+ miles had on the left side here for UCSF, right, about a 47% in person compared to those who had to drive less, which had a 57% use of in person. So it's about a 10 percentage point difference. So again, just gives you a sense a bit more of the magnitude of these results. And again, at Kaiser, which also had a statistically significant relationship, you can see the magnitude is actually even smaller. It's just 41% versus 43%. So just a couple percentage points difference. So overall, even though we are observing some of these statistically significant differences, you can see that sort of the magnitudes are not huge. So again, there are differences, but you can still see that these compositions across all 3 modalities look, somewhat similar. Okay, so this is the slide I said I would come back to just look at the hypotheses and which ones were supported by our findings. So the driving distance from home to clinic, I think, is our strongest result because we found that it was true at both sites. And again, the literature in general has said that those who have to travel farther distances are more likely to use telemedicine. Almost feels obvious, but again, for this population, we wanted to know if that was true as well. So we did find support for that. And then I'd say for some of the other hypotheses, some support, but mixed. Either wasn't true at both sites, or the magnitudes, weren't as substantial. So again, we did see that older people were more likely, like the oldest old cohort, were more likely to use telemedicine, and perhaps somewhat more likely to use video visits. And those with limited English proficiency were less likely to use telemedicine. Again, that had been found more broadly in the literature, and we found some support for that here too. Those with lower socioeconomic status were less likely to use telemedicine. And we saw, again, some support that they were less likely to use video over phone visits when picking telemedicine. And again, these caregiver results, I think just was, we could hypothesize it either way, that you definitely, we think, would need a caregiver for an in-person visit, but you also likely would need one for a telemedicine visit. So again, a little bit hard to say sort of what the best hypothesis was there. And again, our results, I don't think should be taken as causal in any way, because of just the question of whether caregiver is accurately documented. Okay, so that was sort of the first set of analyses we did, just looking at the demographic relationships between use of telemedicine and different modalities of primary care. And then we moved on to, I think, perhaps the more valuable questions of like, is it actually delivering value to this population? First, looking at the question of timeliness of care. And so what I'm going to show here is just first the at the top here, the summary statistics for the timeliness. So you can see that the average time between scheduling an encounter within this 0 to 30-day window was about 10 days at UCSF and about 4.5 days at Kaiser. So Kaiser was already doing a better job of getting people in a more timely way. And again, you can see the breakdown in terms of percent that we're getting in between 0 and 3 days, 4 to 7 days, et cetera. So then below here, we have the regression results. And if you look at this very first row where it says overall, you can see at UCSF, telemedicine was associated with more timely visits, again, but not statistically significant. So it was about 1 day shorter, again, on that basis of about 10 days. So, you could roughly say about, a 10% shorter time between scheduling and when you actually had the visit. But for Kaiser, I'd say, much more dramatic results. You can see there that it was associated, telemedicine was associated with 2.26 fewer days between scheduling and appointment. And again, that's on the basis of an average of 4.5 days. So it almost cut the time between scheduling and visit in half. So that's a pretty impressive gain in terms of timeliness and access to care. We then just stratified this to see if the timeliness benefits were, consistent across different demographic groups. And you can see on the Kaiser side, like they were just very consistent, and no matter sort of how we cut the data, the timeliness benefits seem to be about the same. At UCSF, you can see the one timeliness subgroup that was statistically significant was those who had somewhat lower severity. So between 0 and 4 comorbidities as opposed to more than 4 comorbidities. And again, you can see that timeliness benefit was just about just under 2 days. So again, for timeliness, we are seeing very strong effects on the Kaiser side, and I'd say consistent effects on the UCSF side, but not statistically significant. Okay. And so let me move to my last research question here. I hope this is an okay pace given the broad set of results that I'm sharing today. And so the question here again was, are there potential unintended consequences of using telemedicine? And it could be that if the modality of care is not able to address the needs in the visit, that you could then see an increase in near-term ED visits or hospitalizations, or follow-up primary care. For follow-up primary care, I don't think that's necessarily a bad outcome, but it just means that the telemedicine visit likely wasn't able to address the needs, and so they did have to come in for a face-to-face visit. So here are the results, and so let me just walk you through them. So at both sites, what you can see is whether the patient was admitted to the hospital after an in-person visit versus after a telemedicine visit did not vary. So at UCSF, about 2.3-ish% of people got admitted to the hospital after an in-person or telemedicine visit, but didn't differ by modality. And the same for Kaiser, though their levels are a bit lower. But the point is no difference between in-person and telemedicine. So the sort of most concerning outcome that we would think, like were they admitted to the hospital after a visit, didn't differ for in-person versus telemedicine. Then what about, did they go to the ED after a visit? At UCSF, you can see again, no difference between in-person and telemedicine. And in fact, the average is a bit higher for in-person. So again, not seeing a strong concern that telemedicine might be leading to the need to go to the ED. At Kaiser, there actually was a statistically significantly higher level of ED visits after a telemedicine as compared to a face-to-face. You can see it's about 1 percentage point higher, so it's not a huge effect. But it is a bit higher. So again, something to consider. And could that mean that there is something, about the telemedicine modality that's, that's not catching, something that's critical that is resulting in the need for the person to go to an emergency department after the visit? And then was there a need for an in-person PCP visit after either an in-person versus telemedicine visit? Again, at UCSF, you can see, that there's no statistically significant difference. Again, maybe argue slightly higher level of a need for an in-person visit after a telemedicine visit. For Kaiser, we do see, again, a statistically significant difference where after a telemedicine visit, 3% are needing an in-person visit compared to 1.1% after an in-person visit. So again, some potential signal that there's a need for an in-person visit after a telemedicine visit. Okay, so let me just talk about the limitations of this study. You've now made it through all of the results. I've mentioned it several times, right? But we just had a very small, actually surprisingly small sample at UCSF. We, think of ourselves as, seeing, a pretty, like a population where we were expecting that we would have more individuals, but it seems like that was just did not bear out in the data. And so again, that's why I tried to highlight where our results were similar to Kaiser, but not statistically significant, because we think that they're probably underpowered. Though again, hard to know for sure if that's what's driving it. We talked a lot about underdiagnosis of dementia. We know that this in general is a major issue. And so there's no doubt that there are more people with dementia in our populations that we treat, that we just don't have documentation of their diagnosis in the electronic health record. I don't think that impacted our study results, other than potentially that, we have a more severe population that we're picking up because they do have documentation of their dementia diagnosis. So it is possible that what we're seeing is, is sort of a more severe dementia population, as opposed to those who might be only recently starting to show symptoms. Talked already about the biased caregiver presence measure. Again, I just don't know that there's so much to read into those, but I think a lot of interest in the role of caregivers in supporting how care is received. So a really important topic area. I just think not one that you can reliably use EHR data to study. And then just a whole bunch of unmeasurable contextual factors that relate to what modality is selected. So we have no ability to know when telemedicine is used versus in-person. Is it patient preference? Is it clinician preference? Is it what was available at the time that the appointment was scheduled? It's likely all of these play a role, and in any given situation, it will be important to understand these differences. So that we can start to understand more about how modality selection is playing into the results that we see. We also know that there are differences in scheduling practices, PCP availability, and other clinic and site level factors. So again, knowing sort of what the options were is, I think, a really hard part of this to do using secondary data analysis, and will something that we'll try to explore in the future as we do some of our survey-based work. And again, reason for visit, reason for the initial visit, reason for the subsequent utilization. We don't have reliable measures of those. Again, they tend to be, just very shorthand free text fields if they're captured at all. So we did actually try to look at that, but it just proved to be unreliable data. We don't know much, again, about the patient functional status, which could impact their ability to come in person or use telemedicine, or mobility status, and also level of education, which is something that's been looked at a lot in the telemedicine literature, but we didn't have a consistent way to capture at both sites. So a lot of additional important things to study and understand around the results that I presented today. So summary of key findings. So again, we saw a very large increase in telemedicine use among people with dementia in the post-pandemic period at both sites. Again, we're seeing that that really, there's a large chunk of in-person visits that seem like they were probably could have been supported by telemedicine all along. And now that it's a routinely available option for care, we are seeing that there's a large uptake among this population. The driving distance results, I think, is a really important one, that we're saving people all of the stress and inconvenience that goes along with needing to drive to an appointment. And so that is very strongly associated with use of telemedicine. And then, some interesting other results. I don't think we were expecting to find that those over age 90 were going to be most likely to use telemedicine. So again, I think a good signal that there's comfort with using this technology. Again, undoubtedly with the support of a caregiver, but even for the oldest that we saw some of the highest levels of use in that population. But again, patients with limited English proficiency were using it at somewhat lower levels. So it suggests maybe the need to do some work around making sure that telemedicine is accessible in all languages. Okay, and timeliness of care. Again, both sites, we saw promising evidence that telemedicine was supporting more timely access to care. But really, I'd say, with the most dramatic results at Kaiser, where it was cutting the time between scheduling and visit by almost half. And again, true across all subgroups. And then the post-visit utilization outcomes, I'd say, again, it could signal that there's some instances in which telemedicine is being used in ways that might not be, optimal, because there is a slightly higher need to go to the ED after a telemedicine visit, but again, relatively small magnitude effect size. And then this follow-up in-person visit, again, small magnitude effect size, but it could suggest that there are some cases where there's the issue is recognized during the telemedicine encounter, something that needs a face-to-face follow-up. And again, I don't think that's surprising. And it's helpful to know how often that happens, that there's a need for a face-to-face following a telemedicine encounter. So, and again, nothing on the hospitalization side, which would really be the biggest concern if we saw, a large uptick in hospitalizations after telemedicine encounters compared to face-to-face. That would, I think, have really been a concerning result. So all in all, I think we feel like these post-utilization outcomes suggest that telemedicine, even at this very expanded rate that is being used safely and effectively. Okay, so we are now almost to the end of the talk, and I want to just tell you what's coming next, because the overall goal of this partly was, to just be able to characterize where we are today with respect to use of telemedicine in primary care for this population, but to really identify strategies to optimize the use of telemedicine. Are there ways in which the technology itself or the way that it's integrated could better serve this population? So what we are starting, we're almost finished actually with our evidence synthesis to understand what's already known about how telemedicine could be better targeted to this population. And I'll say there's not a lot of evidence out there that studied this question. We didn't think there was, but which is part of the reason to do this work. But we have not found a lot, at least that's sort of very specific to dementia. and the needs of the dementia population. Mostly we're finding general things like the language accessibility and other things. So the next step will be to convene an expert panel that will look at what's known from the literature and then also add their own insights to think about some of the strategies that could be used. And then turn that ultimately into a survey for PCPs where we will ask them to prioritize the strategies based on feasibility and impact. And then take those prioritized strategies back to key stakeholders. We expect that there might be some changes, for example, recommended to the EHR and EHR design that could help support telemedicine visits in this population. But there also may be some things related to sort of how telemedicine is offered or when clinicians recommend a telemedicine versus a face-to-face visit. So we're really excited to do this work over the next 12 to 18 months to be able to come up with these strategies that we hope will further improve the ability to use telemedicine to deliver care to this population in the primary care setting. So this work has been done with support from NIA, and as I said, this team at UCSF as well as Kaiser, that's a mix of health services researchers and health IT researchers like me who are very interested in the technology piece, as well as experts in dementia care and in primary care. And so together, I think we've been able to sort of leverage all the different types of expertise you need to do this type of work. And as I said, ultimately, I hope we'll come up with recommendations that can meaningfully improve care for this population. So that is it. I think I'll stop sharing my slides as we move into Q&A, but if I need to pull them up to go back to anything, I'm happy to do that.
Thank you so much for this great presentation. And just to remind our attendees that you can put any questions you have for our speaker in the Q&A feature using the Zoom Q&A on the bottom of your screen. And while folks may be doing that, I'll start first with a question. You mentioned that the telemedicine platform overall was quite accessible for people with varying cognitive abilities, different ages. I'm wondering if you think that, and I think with COVID, we saw that even more, that the technology became more accessible and maybe a smaller group of people were left out. But do you see any further need for increasing the inclusivity of telemedicine platforms? And are there things that can be done, not just from a technology perspective, but maybe from policy or things that health systems should be doing to maximize access?
Yeah, it's a great question. And I think it allows me to talk about a couple pieces that I didn't get to in my presentation. So first, I will just say that I think both organizations require that people be on the portal, the patient portal, in order to use telemedicine. And so that was, I'd say, like a major effort was just to get people portal access to then be able to use telemedicine. And then I think Kaiser uses I don't know if it's a homegrown, but like they have a very integrated telemedicine platform, whereas at UCSF we use Zoom, which is, it's not as directly integrated into the electronic health record. And so I think just there still is a need just to sort of figure out all of the technical workflows that help give people access. Again, I think people were forced to learn how to do those during the pandemic, and we saw, large increases. But we also have been studying things like, telemedicine visits that couldn't be completed due to technical barriers. And there are, it's not huge, but there are, a meaningful number of encounters that, for example, are scheduled for video and then have to switch to phone because the video doesn't work. So I think it will just be important to continue to kind of monitor how often people are on the portal, how often these encounters can't be completed due to technical access barriers. But I will say too that at UCSF, because we had to make this switch so rapidly, and we're really worried about, the subset of patients who we thought would struggle to access the technology. So we implemented a very specific program in our primary care clinics that basically would reach out to people who were not on the portal already, and we thought would generally have, based on their sociodemographic characteristics, might have access challenges. And we did a pre-training session with them before their visit. So we sort of added a step to try to help make sure that they knew how to, access telemedicine before their actual encounter. And so we actually think that it's possible that some of the differences in the socioeconomic status results that we saw for UCSF versus Kaiser might be attributable to that program that specifically sought to close that barrier. And there's been some separate assessments just of that program. So I do think, in populations, for health systems that are serving populations that they think may struggle with technology use and digital literacy, that we are seeing examples of interventions that just specifically target that use case. Again, in the dementia population, I think there's probably, we should be learning about customized versions of that, and even just beginning with how do you identify who the caregiver is, who's going to be supporting the individual in that encounter, and making sure that they are the ones that have the training, or that have the proxy access in the patient portal. So I think for all of these general strategies, there is definitely a need to think about how it might need to be tailored in the setting of dementia care. So again, that's at the health system level, where I think there's definitely opportunity to close some remaining gaps. At the policy level, I think it's a more complex question, because there's sort of so many levers. I mean, I think one is obviously just the payment parity around telemedicine. And again, part of the reason I hope our results are impactful is that there's this concern that opening up telemedicine is going to really increase just utilization of care. And so I think one set of our results is showing that, that we're not seeing that they really are used as just, basically a substitute for in-person care rather than just an additive visit. And so I hope that helps just achieve some of the payment parity on an ongoing basis. And then I think, there is the opportunity to take some of the existing federal regulations around meaningful use of technology and to think about how they can be used to ensure equitable use across different patient populations. Yeah, I mean, I think first we need to show that there's a problem, right? Before, policy is the right intervention. And I actually have to say, again, after looking at our results, we are seeing very high levels of use among a population that many people hypothesized would struggle. So I'm not seeing a very strong imperative to kind of come in with swift policy action. But especially as we can better understand some of the tailoring strategies that might be useful, then I think having policy come in to push those, if we're not seeing those taken up, naturally by health systems or EHR vendors, et cetera, that could be a good role for policy. So I think the short version is continuing to pay for telemedicine, I think, is important. But beyond that, I'm not sure that there's a really strong need for policy intervention specifically around technology, how, telemedicine is being used in this population, because I think we're seeing a lot of promising use just naturally without the further policies.
Great. We got a lot of questions that have to do with your methods and your results in terms of more detail. So I'll go through some of them quickly, I guess. So one question had to do with the measuring time beyond driving time. Was the time to travel to clinic considered, especially for the Bay Area, with different options, public transit, accessible van services, and so forth?
Yeah, it's a great question. And unfortunately, we don't capture the mode of transportation used to get to the visit. So it is possible that even if they lived closer, if they didn't have a car or an accessible bus route, that it was taking them much longer to get there than it would have been just to drive. So I think it's again a really good point. And I think the urban environment, when you're studying travel time, because it's just parking time can be actually longer than the driving time. So there, to dig into that, there's a lot to do there. But again, within the constraints of what we have measured, and we unfortunately don't have the ability to go deeper there.
Another question has to do with the rationale for setting the time window to 14 days.
Yeah, that's a great question. I think we basically had to set it somewhere, because, right, like a hospitalization 6 months after the visit clearly felt like not, too far out. But could we have done 30 days? Like, yes, we could have. And I think we actually did do a 30-day sensitivity analysis and saw very similar results. But ultimately, I think it was, sort of the closer we got to the index visit, the more confident we were that that visit's modality might have had an impact. So 14 days felt like, to us, I think, like a reasonable place to set it, between, 7 days, which is, I'd say very short, but would have been justifiable, and 30 days, which felt like maybe the outer limit of something that we felt like would be attributable.
Another question about your results. Could it be that Kaiser is referring their patients to the ED? Does the severity of the patient episode have any impact on how early the appointment is made and maybe impact referral to EDs?
Yeah, that's a great question. I mean, I don't think Kaiser uniquely refers to the ED, but I think if someone, is having an emergent issue and can't get in, then yes, they would be. But again, you could see that their visits were already more timely to begin with. And in general, you could get a telemedicine visit within a day or two. So the fact that they, I think, have actually probably the best telemedicine access and also had the somewhat higher levels of ED, I don't think it's a sort of referral to ED explanation. I think it may actually be that they're using telemedicine so broadly, and that there are just some instances where telemedicine is being used for a case that is an emergency, and they therefore need to go to the emergency room. So that's, I think it's that's the more likely explanation.
In a follow-up from the same person, in your results, telemedicine use was less when caregivers were present. If that's indeed the case, some caregivers may be paid. So are caregivers compensated at a higher rate for in-person visit versus telemedicine?
Yeah. So as I said, I'm very skeptical about whether there really is less caregiver involvement in telemedicine. I just think they may not be visible as the supporter, whereas if they're in person, you will like see that caregiver. And caregivers come in all forms, paid, unpaid. And so I am not aware of any payment models that are specifically designed to help support in-person versus telemedicine visits. So that's an interesting, until you'd asked that question, I hadn't even thought about that. But I think my sense is that supporting access to medical care is like usually part of caregiving responsibility, and that we haven't gone beyond that to think about, that there might be more or less burden or work associated with supporting access to different types of visits. So I think it would be really interesting to do some analysis in the caregiver community around the implications of these different modalities and what that means in terms of caregiving burden, but not something that I can speak to directly from our results.
Another question is about whether other conditions like heart failure or other comorbidities played a role as covariates.
Yeah, it's a great question. And I'm glad it was brought up for two. So just to directly answer the question, I mean, I think we have the data to look at those, and would love suggestions for some hypotheses that you think would be interesting to test, that like heart failure, for example, because I imagine it's more critical, where we might see like lower levels of telemedicine use, because of just being, more concerned that someone needs to be seen face to face for that. So I think our study is set up to be able to explore some of those. But I'll also say, just I think more generally, what I hope our study also is an example of is like the ability to study telemedicine use in any population, right? So we picked primary care for people with dementia, but like really you could pick any population and use, I think, the same study setup and the same way of defining the encounters. So what I hope our study does is also help make it easier to be able to ask these types of questions in lots of different populations of interest, so that we can understand how to tailor telemedicine to all the different populations that may need to use it in different ways. So you can think of just people with mobility challenges, for example. that might be another subpopulation to look at. So again, if I suspect in this group we're collectively interested in in dementia and other diseases of aging, but I do think this study as a template could be used in a lot of different types of populations.
Are there any differences in pre-screening for scheduling what type of visit for the two sites, with Kaiser Permanente being a closed system?
Yeah, so we really wanted to capture that, like the decision making around modality and like how that happened, and it's not captured as structured data, and so that to my mind is actually the major limitation or opportunity for where to go next with this research, is to really understand like when the patient is calling and how they're describing their symptoms and needs, and then how are they getting directed, because some of these people are actually even self-scheduling. Like you can go and just pick pick your own appointment time without even talking to someone. So there's lots of heterogeneity, I think, in around how that's happening, and so again, that would, I think, just be its own study to really understand all the factors that are leading to then the selection of the encounter modality that we observe.
And I'll try and summarize or merge two other questions or comments. The first one has to do with how the stipend for broadband, or also known as the Affordable Connectivity Program, has been canceled as of June 1, 2024. So your study and its findings could have a significant impact in helping advocate for looking at bridging the digital divide. And the second comment or question is your thoughts around telemedicine helping to broaden the selection of providers.
Yes. So sorry, just repeat the second question. I want to be sure I'm understanding.
The second question is, does telemedicine help broaden the selection of providers?
Got it. So if I understand that question correctly, so it's sort of among primary care providers, that you're more likely to get someone in a pool as opposed to like your dedicated PCP.
That's how
Yeah. So in general, yes, I think that is likely happening, that you're just getting the first available rather than your PCP, which if you were scheduling like a year in advance, you would probably be more likely to pick a particular provider. And I think it's a super interesting question of sort of, it's a type of care fragmentation. It's sort of like you're seeing someone different than who you saw before and who you might have an established care relationship with, and the implications of that. And I actually think that's a question we could probably study, because we know who the individual was who delivered each encounter. So we could look at some measure of sort of whether telemedicine increases fragmentation, so to speak, of like the individual clinician that you have contact with. So that's a great idea. I love that idea. And I think would be really interesting to assess if that has an impact.
Well, I know this generated a lot of questions and comments, and so if folks have further comments or wish to discuss, I would suggest that they contact you directly. I want to thank you again so much for this wonderful presentation. Remind our attendees that this will be uploaded to our YouTube channel in about a week or so you can watch the recording. Our next webinar is Thursday, January 9th, again at noon, with Dr. Den Ouden from the University of Applied Sciences in the Netherlands, talking about from healthcare professionals versus technology to a model of healthcare professionals with technology. Again, thank you to our speaker and our attendees, and see you next month.